All right, and then I need to share my screen. All right. So this is an interesting little misadventure. As David likes to call it, iatrogenosis imperfecta. So this patient has this complex pleural effusion, and I'll show you what it looks like on CT. Patient presented with pancreatitis and has this multiloculated effusion. You can see there's some little bit of pleural thickening, enhancement, and tethering of the lung. So presumption was this was probably going to be an empyema, but they wanted to drain it. And you'll see there's some little bit of fluid in the upper abdomen, had some peripancreatic abscesses and all this badness. So this was the post-procedural radiograph, and this is one of these tough cases. And I remember the person who put the drain in came and asked about it, and you see there's a nice pigtail catheter here, and it's formed the pigtail. This was placed under ultrasound at the bedside, and you can see it's between the probably about the 12th and 11th rib. So and they were aiming for that posterior recess, and look, for all the world, looks pretty good. They said they weren't getting a lot of fluid out of it, but sometimes that happens when you go in these pockets. And here was the radiograph. However, now we're about 5 days later, and you'll notice there's been really no change in all these loculations. The pigtail's still there, and at this point they weren't getting much out, and we never had any other imaging. Just a couple radiographs in between, but they all showed the same thing, that effusion wasn't draining. So they instilled TPA or whatever in the drain, which is commonly done to help break up some fibrin and stuff in the pleural space, hoping to get this out. And nothing really happened, but a little bit later, the patient was, their hematocrit dropped a little bit. And so this is a chest CT that was just done looking for hemorrhage or something like that. And you can see there's the loculation of pleural liquid here. There's bubbles of gas in it. Still there, and so now there's gas in it, looking more like an empyema, but where's the drain? It's not there. And it's not until you go down that you see there's the drain, and it goes through the spleen into this little collection right by the stomach where there was part of that peripancreatic abscess. You can see the interventional radiologist had put some drains in anteriorly there for this peripancreatic abscess. So somehow during placement under ultrasound, and my guess is because the spleen is so hypoechoic on ultrasound, it could have easily been mistaken for a pocket of sort of dirty pleural fluid. There's not a lot of space between it. There's really no fat in between it. And so, and typically when you go into the outside the pleural space, the pigtail won't form. And I always show my residents cases of ones that went in the chest wall or went below the diaphragm, and the pigtail it doesn't form because it needs a space. But this one somehow happened to go into a pocket of this peripancreatic fluid where they were able to form the pigtail, and once that was drained, nothing else came out of the drain. So yeah, one of these cases, and you go back to the radiograph and ask yourself, was there anything we could have thought of that suggested this wasn't intrapleural? I mean, it was noted on multiple studies that the pleural effusion hadn't changed, but when you have these multiloculated collections, sometimes they don't change until someone goes in there surgically and cleans them out. So, and I showed you guys one recently of the drain going, the central line going into the pleural space, but it was overlying the SVC, and this just reiterates the point that when we're limited to one projection, we can misinterpret things just because of the way things line up.
Yep, definitely difficulty.
Yeah, and so probably what happened was when the TPA was given, it caused bleeding, and that's why the hematocrit dropped. Now here's another little technical thing, and some of you may have seen this, but one of my colleagues showed me this case. This is a great case. So this was a chest radiograph, and I can't remember what it was done for. And this was done at a different facility, not at our particular hospital, but they were using a CAD system here, and you can see the CAD identified 3 abnormalities. One is the left hilum, one is the intralobar that's sort of a little bit foreshortened, and I'm not sure what it's circling up here. But if we go back to the original radiograph, you'll see that there's an abnormal contour along the right superior mediastinal margin, and the paratracheal stripe looks a little full, and there's this convexity up in here. And that was not detected by CAD. And you'll see on CT that wasn't a little finding, but rather a sizable cancer in the right upper lobe. So while, CAD definitely has its role, it's not perfect. And one of the downsides is it not only do people get so used to the false positives, which just happens with the current algorithms, is they may overlook the real finding in there. So that's why it's always important to interpret it without the CAD first, because I don't think any of us would have worried about these two areas or whatever it was thinking was up here, but hopefully that would be an area where we catch something. It's right where the first rib comes in, which is a place cancers like to hide, but this is really dense and has a sharp margin, so it should be pretty visible.
Yep, very instructive.
Yeah. And this is an interesting case. This is pretty striking, and I think this follows up on one of your previous cases, Howard. This is a patient with known renal cell carcinoma, and you'll see there's a bunch of nodules in the lung, but at close inspection, you'll realize that lots of them are branching. They're more tubular in shape. We've got a bunch of dilated structures here, and you can follow these out from these vessels. And so this is probably the most extensive example of intravascular metastases I have seen in renal cell or anything else. I mean, there's some well-defined solid nodules, but the majority of these are centered on nodules. And I think there's also one in the airway up top. And renal cell is probably the most common to do this one. This one here seems to be in this branching structure, and as we go down, you'll see there's an airway, or it may be in the vessel. It may actually be in the vessel next to it, compressing the airway. I'll bring in the nips just to show this distribution, just how extensive these are. But I would say the majority of these are actually endovascular. But this is the worst example I've seen. I've seen it with hepatocellular and occasionally with sarcoma, but renal cell is the one I always think about when I see this.
Yeah. Is there any ill-defined opacity about the ones in the right lower lobe, such that there may be actual ischemia from vessel occlusion?
Well, there is this ground glass here.
It's hard to know, it could be a little something, a bit of...
It's a little too lobular for atelectasis, but hard to say in that patient.
Hard to say, of course. But given the size of them and the vascular occlusion, I've seen at least 2 cases that I can remember in which I was pretty convinced that there was associated focal hemorrhage or hemorrhagic infarction with the lesions on 2 occasions, I recall. That could happen.
Yeah, they are enhancing, which is typical of renal cell, and these aren't mucus plugs if there was any doubt. Not much disease in the abdomen, but it's just, this was striking. Okay, and then this is another case that is sort of, this was a presentation. So this patient, this was the first scan the patient had. They had, this was staging for gastric cancer, and this is one of the worst cases of lymphangitic carcinomatosis that I have seen. One of my colleagues saw this case, but we've got the septal lines, like you can see, but one of the findings I find very helpful, especially in distinguishing this from edema, is the shaggy vessels, the shaggy veins in particular. You can see this just irregularity. You can get engorged veins, you can get thickening around the veins with edema, but this is very nodular, and the only thing I would see this with was maybe sarcoid, but this appearance is not typical of sarcoid. But as we go, you can see pretty much everything is involved. There's thickening of the bronchovascular bundles all the way down. There's not a lot of normal lung, but this was at presentation here. So, and you see it along the fissures too. You can see that nodularity, which is very helpful, because otherwise you have very smooth septa, which is, you might see with edema as well. Now, one thing I was looking for, Howard, is see if you get any of those lymphatic or lakes or pearls or whatever we like to call them with lymphangitic tumor, but I've not ever seen it. I've only seen it with just simple edema.
With hydrostatic edema,
yeah. Because I don't see them here.
Yeah. What was the primary on your lymphangitic case?
Adenocarcinoma of the stomach.
Yeah, this appearance is very similar to a case I showed about 3 weeks ago that turned out to be the same diagnosis. But if you put the 2 side by side, and you made the same comment about some of the vessels in the case that I showed, the 2 cases side by side would look identical to this.
Right.
So very, very similar.
Yeah, and you can see even this vein. Sometimes you'll see little, almost like tree and bud veins. You get these little and the shagginess around them. And also the little side branches become very conspicuous because they're engorged. But yeah, sometimes it can be challenging, but I think this case it was not a problem.
Well, it
Okay,
used to be, Jeff,
Yep.
the old literature was that the most common cause of lymphangitic carcinomatosis was gastric cancer. But those statistics were left over from the days in which gastric cancer was common in this country, and it's become much less common after World War II. So the most common primary that we see it with, I think these days, is breast cancer.
Or lung.
I see. Or lung.
Because it's right there. Yeah. Yeah. And that's right. I've seen it a couple of times with prostate, but very rarely. And I've seen one case of renal cell, but that's it. You're right. It's almost always breast. And then I think lung is very common just because lung is common and it doesn't have very far to travel. Okay, speaking of travel, I've got two good infection cases to wrap up. So this is a new one for me. This was a 27-year-old woman who had immigrated from the Gambia, so that's in Western Africa, and she had presented with a bunch of vague symptoms, but some chest pain and some low sort of pain around her buttocks, and some swelling in her neck. And so I have some of her imaging. I don't have all the old imaging because it was done elsewhere. But one thing you'll see immediately is there's this destructive lesion in this posterior rib. And this was back in 2017. So soft tissue mass. And, she's 27, so metastasis is not the most likely thing. But she also has lymphadenopathy in the subcarinal space. And then if we go further down, I think I have it. This is an abdomen pelvis. Yeah, let's get further down in the system here. We go down. You can see she's got this destructive process with some necrosis right around her sacrum, and sort of the sacrococcygeal area there. So, multiple lytic veins and lymphadenopathy. You'd have to entertain tumor, but given that she's from West Africa, you'd have to think about mycobacterial disease, especially at her young age. And so she had been sort of followed along there, and I don't know what kind of treatment she's getting, but this was a follow-up done about 8 months later. And you can see the lytic lesion is still there, but now she's developed back here in her chest wall muscles. Let's see if I can bring it out. It's very subtle, but right in here, she's developed a chest wall abscess. It's a little bit lower attenuation. You can see the asymmetry in the muscles that wasn't there before. She's still, her lymphadenopathy is better. That subcarinal lymph node mass is a little bit smaller, but overall still not normal. And this is just, I don't think I have we didn't have another abdomen to follow up. But what's interesting is what they grew out of this. They didn't grow out MTB, but rather this other organism, if I can bring it up, called Mycobacterium africanum, which is pretty self-explanatory, but I didn't know much about it. So I pulled this epidemiology article from Emerging Infectious Diseases, and it's published by the CDC. And what this is it's part of the TB complex. So it's not M. tuberculosis, but they're now referring to the M. tuberculosis complex, sort of like with Nocardia asteroides complex and Mycobacterium avium complex. So it causes TB-like disease, but the vast majority of cases are isolated to West Africa. So it's now with all the DNA probes and stuff, they're able to speciate these much better. But overall, the infection seems to be a little pretty similar as far as location. They get in all this microbiology stuff in there about different features, which you can read if you like. But what's kind of interesting is that these are the only cases reported in the United States over about a 9-year period. And there we are right there in Dane County. And you can see it's pretty much in the larger metropolitan areas. You can see, David, there's most of your area, and I think, Howard, you're here, and Seth's down here, and Travis is up here. So all the major metropolitan areas. Probably where you have a West African immigrant population. We see them primarily at the university, but also some come here for other reasons. So
Jeff,
yeah,
we missed part of your presentation. Your sound went out.
Oh,
is this clinically similar to TB in terms of severity and
yes,
sites and things?
It causes the disease called tuberculosis.
I see.
Yes, but she didn't have pulmonary involvement, interestingly. She presented with just soft tissue and bone involvement, but the route of entry is still the lung. She presumably got it in her lymphatics, hence the lymphadenopathy, and just it cleared in the lung, but it didn't clear elsewhere and seeded the bones. And she's been under treatment, but it seems like this particular strain is harder to treat because even after 8 months, she developed a new soft tissue abscess, and the bone lesion hadn't quite gone away. The lymphadenopathy was getting smaller, but it behaves just like MTB.
It was nice low attenuation in the lymphadenopathy too.
It was. Yeah, it's easier on a different phase of contrast or no contrast altogether. But yeah, you can see it up here that it is pretty low attenuation. It's very heterogeneous. Mm-hmm. So, especially in younger people, they're not. I mean, it could be metastases, but got to think about TB in the right place. And then this last quick one. This is just a nice case where we got microbiologic confirmation, and shows something that I think has been talked about in the literature. So this is a young man, I think he was in his mid-30s, presented with this radiograph here, and you can, there we go. And you can see that he's got consolidation in the left lung. It looks like pleural effusion, pretty dense in here, but primarily in the left. And it came in with fever, cough, white blood cell count. So this is on day of presentation. Actually, here's the earlier one. So this is the early afternoon of that day. You can see there's consolidation. It's denser in the left lower lobe. And then this is about, 7 hours later. It's getting worse, maybe some effusion. He's probably being resuscitated. At this point, he was admitted. He was looking quite ill. There may be some lymphadenopathy in here. So that was at presentation. Here he is the next morning, about 5 hours later. Now he's intubated, and still see it on this side. So he's going into respiratory failure rather quickly and becoming hypotensive. And then here he is subsequently thereafter. So this moved really fast in the course of less than 48 hours, went from, sort of focal disease to multilobar to bilateral, intubated in the ICU. And this, the sputum PCR came back positive for the Legionella stain, or PCR came back positive. So this is Legionnaire's disease, Legionella pneumophila. And I remember this, and I don't know if it was you, David, who taught me this, but it tends to move. It starts off unilaterally, but it tends to become bilateral rather quickly because it's usually talked about as a bronchopneumonia, but in this case, it started lobar. It just moves really fast, and that's why these patients get so sick. You can see this is a young, healthy man who's now in the ICU on a ventilator.
I wonder what his risk factors were. So you're right. So Legionella is famous for presentation, being bilateral at presentation. So it's pretty aggressive. But for a young man, I mean, why is he getting this? Is he immune compromised in any way, or was he taking showers 20 hours a day or something like that and just inhaling the mist or something like that? There's got to be some risk factor for a young guy like this.
Yeah, I don't know, other than we had a hot week last week and the air conditioners were all probably fired up after sitting dormant for some time.
That's it. Maybe the stuff had been growing there for months.
Yeah, I don't think they got a very good history because he was so sick and ended up decompensating so quickly. I'll have to follow up on it and see if there's anything. But yeah, I mean, but it's a community-acquired infection, and I mean, with the original outbreak back in, was it 76 in Philadelphia? I mean, it was at a hotel,
right,
in the HVAC system.
Yeah.
The cutest case that I heard about or read, I can't remember where, about a young person that got this, and someone was really smart and got a detailed history. So in his case, it turned out that he delivered flowers for a flower shop, and he delivered a lot of flowers to a hospital. So they asked him what he did, and that's what he described. And then someone found a water feature. I think it was a waterfall, a mini waterfall in the hospital lobby with a little spray, and he walked past it all the time. And when they cultured the water, it was loaded with Legionella. So they thought that he got it from just inhaling the droplets every time he delivered flowers to someone's room. He walked through the hospital lobby. Why other people didn't get sick, we don't know, but that was pretty cute. Someone was pretty smart.
Well, it's funny you mentioned that because we have 3 hospitals in the Madison area. And I remember a few years ago, they shut 2 of them, not ours. They had fountains in their lobby, in their atrium. We actually had one too. And they found Legionella in both of them. And they shut them off, and we had a fountain that was off for about a year. And I remember that because I always would quiz the medical students, ask them why the fountain was never running, and they finally ended up removing the fountain.
Maybe there was a case I read about, or somehow I heard
Yeah,
about that.
may have
Or
made the
who
national news. I can't remember, but there were a couple cases of Legionella in the county, and I'm not sure if they were linked, but I know someone at some point checked the fountains at this other hospital, and lo and behold, they were positive. So that may be it.
That could be it, that I read somewhere or something.
Okay. Well, that's what I have. So either David or Howard, you guys can go.
Let me go ahead.
Okay.
That's okay.
That's would be great.
Let me restrict the sharing here for 1 second. Pull up the right images here. So here's can you offer me the share again here? I don't know whether I can pull it out. So maybe can I make myself the presenter here, or I will share. There we go. Okay, so here's a young woman who had a bone marrow transplant and is in the hospital, and this radiograph was taken around the time of her transplant. So she's about, I think she's currently about 60 days out. So at this point, I think is around the time of her transplant. And she was feeling okay at this point. And at this point, she has this, she had some symptoms. I think she had a cough, and she's got this subtle consolidation here around her hilum. So it's a little different from before. And she got a CT scan around this time, and she has a localized round infection here that was new, was not previously present on CT. And you can see it has a low attenuation center, so it's a nodular infection. It looks as if it's trying to cavitate. And so consideration here would be fungal infection. This wouldn't be bad for Aspergillus. So in our list of round infections, we have Aspergillus, some other fungi, nocardia, and occasionally we consider Legionella mcdadii as a cause of a round infection that looks like Aspergillus, but usually progresses faster. And this indeed progressed. And you can see that a few days later, it's more extensive near the left hilum, and is now considerable part of the left lower lobe with the accompanying left pleural effusion. And this is Legionella. But instead of being mcdadii, which is the one that I've seen before with these nodular infections, aspergilloid infections, this was pneumophila, again, pneumophila. And it was actually present in the sink of this person's room. So they have shut down the plumbing in that room, and they don't have any patients in that room anymore. So this is Legionella pneumophila here with the mcdadii nodular pattern around pneumonia, apropos of Jeff's case. And this was tracked to the water supply in the room.
David, do you think maybe it's not the organism? Because you're right. I've seen the non-pneumophila Legionella do the same thing, but rather the host immune response or lack thereof that sort of causes this more necrotic mass-like presentation, rather than the more extensive consolidation, like the case I showed, where you have a healthy person with an intact immune system.
I don't know. It would seem to me that the more disseminated form would be what you would associate with having a defective immune system rather than the compact form. I really don't know. There were descriptions of lung abscess, necrosis, and cavitation with Legionella in some of the early reports of Legionella. So when Legionella was a big deal and people were publishing about it, that was one of the patterns. So it's not unique to the population to have a necrotic mass and a lung abscess. So but you raise a good question. What is it that is about these things? For us, we suspect Aspergillus because that goes with our population. It goes with our compromised population. So perhaps you're right. It's mcdadii in that setting. I don't really know. Mm-hmm. Good point. Okay. So let me start with go back to some other cases here. Here's a man who back in 2008, at the time of this radiograph, had a nodule in his right lower lobe that was not picked up. So this was, of course, outside case. We wouldn't do such a thing. And now we have the more current imaging. This is 2017, and you can see that the nodule's gotten bigger. It's very well defined, egg-shaped thing. And at this point, I don't think we have a lateral view. We have expiration for some other procedure unrelated to this. So we have a nodule in the right lower lobe, very well defined, I think middle-aged person. And it's got some interesting findings on CT. It has this low attenuation. It's very well defined. It's in the base, low attenuation in here. So, you know, what do you guys think?
Looks hamartomaoid.
Yeah, and that was a strong consideration. The low attenuation.
Not quite fat.
It's not quite fat, actually. It's around 0. It's about like -2 and -3 Hounsfield units. So it's not loosened enough to be fat.
Mm-hmm.
So so that's that case. Let me show you a similar case now. So this person has an interesting lesion here. Let me get rid of this. An interesting lesion here in the mid-lung on the right. And you can see that it has very nice calcification in it. And it's like the last case, the one on the screen on your left. This is very well-defined lesion. You know, if this is a malignancy, it looks like something low grade. And this one has nice calcium in it. So you'd think about the possibility of, you know, a hamartoma again in this case. Okay, so neither one of these lesions is hamartoma. They're both typical carcinoids. So carcinoid does have calcification in some small percentage of cases. I think it's under 10%. This is a calcified carcinoid. And this was also a carcinoid down here. They're both typical carcinoids. This case on your right had actually spread to lymph nodes. So although it's a typical carcinoid, it had spread to adjacent hilar and mediastinal lymph nodes. It was resected along with the nodes, and there was typical carcinoid in lymph nodes. And there's been no recurrence since this thing was resected a few years ago. I think it was resected in 2013 or 2014. So one carcinoid with calcification, fairly unusual. One carcinoid here with low attenuation but not fat, making you think about hamartoma, but both carcinoids.
Yeah.
We've had a couple cases, David, that, you know, what we've noticed is with the sort of lower dose that we've been doing for the last 9 or so years, that sometimes it's hard to distinguish fat unless it's a lot of it versus areas of whether it's necrosis or whatnot, with some noise coming off, especially because we do thin selections on everyone. So we've been a little bit more cautious over time with just saying, oh, that's fat. I mean, unless it's really clearly fat.
Yeah, it better be very low attenuation. And I agree that we've had some missed calls too based on that. It was lowish attenuation, but it wasn't really low enough to be slam dunk fat. And it was not, in that case, it was not hamartoma. It was something more malignant. Mm-hmm. So I think it was, as a matter of fact, it was an adenocarcinoma, and there was maybe a little bit of a necrosis in it. So yes, be very cautious with that, and maybe with the low dose, low density discrimination, low contrast discrimination is definitely impaired with a low dose. Mm-hmm. That's a caution that we, you know, might want to publicize.
Yeah, you know what's interesting is the calcium in the carcinoid on the right looked more targetoid, almost like granulomatous, like it had, I thought you were going to say, or the chondroid, like you were going to tell me that was a chondroma or a chondrosarc, but
yeah, I agree. It wasn't this. You know, do you think it was C's and O's? I mean, was it that? Let's go back to it. So that was.
It was the second one you shared.
Yeah. So you're supposed to see C's and O's, and I think actually, you know, I could make this into a Cheerio.
Yeah, or I was just wondering even if it was like targetoid, like it was more granulomous. And interesting, there's a calcification just up a little bit from it medially,
Yeah,
like you're in the hilar node, making you wonder, was this a old histo or TB that got engulfed? But carcinoids typically don't engulf things.
right.
Hmm.
Hmm.
Interesting.
Okay, and see, this is when I showed you the Legionella. And then here's a young guy here with some constitutional signs and presentation with a very nice NSIP pattern of lung fibrosis. And you can see that he's got some subpleural sparing. It's mostly a ground glass. There's no accompanying honeycombing here, so really nice NSIP pattern. And then just a couple of months later, this is not even 4 months later, you can see that there has been dramatic progression here.
Wow.
Oh,
Again, it looks like a really advanced fibrotic NSIP in just 4 months. And Sudhakar wanted me to show you this case. Sudhakar also showed me the first of the carcinoid cases to bring to you guys' attention. And this is another case of presumed amyopathic dermatomyositis. The MDA5 antibody, which is I think the key to this very rapid progression of lung fibrosis, with necessity for transplant within months, is pending. It's been ordered, but it's not back yet. So we don't really have the serologic workup here and the definition of this presumed autoimmune disease here with rapidly progressive NSIP pattern. And there was a biopsy earlier that was called NSIP with some features of a lot of fibrogenic foci, but they still considered it most like an NSIP rather than a UIP pattern. So this is a teaser, and I'll have more information later, and I'll bring you guys up to date on it. But Sudhakar proposed. He said that you guys have shown some other cases of this rapidly progressive lung fibrosis in the setting of amyopathic dermatomyositis with MDA5 positivity and all of that. And so wants to know if you guys want to combine cases. So he's putting this out there as bait to collaborate.
Yeah, I need to reach out to our rheumatologist and find out. I know I've seen some rapidly progressive ones, but I don't know if they had that mutation or if we're even able to, or that antibody, if we're even able to test for it. But
it's been around for a couple of years, and that and one other correlate very strongly with this. The last two, I've showed two cases, I think a couple of years ago. We had two women admitted within a few months of each other. They're around 30 years old, and they both had this rapid progressive thing. They both had that same MDA5. I'm trying to figure out, this looks like a guy here, sort of a plump guy. I don't think this is a woman.
yeah.
But we saw two of these cases together, and they both had the same mutation, the same rapid course. It's just astonishing.
Yeah, that is fast.
Yeah. Okay, those are the cases.
All right. Well, thank you. All right, Howard.
okay.
Go.
Okay, this is an interesting case. The background is that this is a relatively young person with metastatic colon cancer. They've treated this person with the regimen that I think is used most often, that has the acronym FOLFOX. And I think the response to it was not great with progressive disease. And as is not that uncommon nowadays, they sometimes send tissue off for next generation sequencing. There are a couple of companies that provide that service. One is called Foundation One, and they look for actionable mutations. And one thing that came back on the tissue for this person is it was positive for HER2. So we typically associate that, of course, with breast cancer, and patients with that in part are treated with the drug that he was started on, which is Herceptin. trastuzumab. So this is after the initiation of trastuzumab therapy. And you can see here in March, he has subsegmental sized, patchy, ground glass, mostly consolidative opacities in the lungs. And then when we go forward in time, it actually seemed to get better, and I'm not quite sure whether the treatment was modified. So on the right-hand side now, we are into May, in which case it's less, except that there is a focus which is new in the right lower lobe. And the more recent one that I saw the other day, and the time between these two is short, you can see he has now much more lung involvement. So again, we have these ground glass attenuating consolidative opacities. Some like this do have the so-called atoll, reverse atoll type appearance. So although I don't have a lung biopsy, I'm pretty convinced that this is organizing pneumonia from that. And I did find one case report, which I thought I kept there. Actually, here it is. So this has been reported here. This is a pathologic proven case of organizing pneumonia in the context of treatment for breast cancer. But I'm pretty convinced that this person has it as well. So I'm not quite sure what they're going to do, but I think his presentation is not suggestive of anything else. He's not acutely ill. And I certainly describe this as very consistent with the drug toxicity that you see there. So time will tell. I'll give you a follow-up if I ever get any, but that's a strong presumptive diagnosis on my part that he has that.
Yeah, very typical appearance, Howard. We see I've seen this with all these new, well, older ones, but also all these new monoclonal antibodies that they're using. This immunotherapy, this organizing pneumonia is showing up rather frequently.
Yeah. Okay, this is a kind of an interesting case. So this patient came to our hospital from elsewhere. She has had encounters with physicians in multiple places in relation to her pacemaker. And at some point in time, they put in a CRT-D device. Now, she may have had something before that, but she, at this point in time, came to us with a CRT-D device. And I'll just make this a bit bigger and see if you can spot where things are not where they should be. Let me bring up the lateral, because there's one observation on the lateral that I didn't initially make. So look at the leads, and you can see that one of them here is not connected to the pacemaker header. So there are a total of 4, 3 of which are connected, 1 of which isn't. But see if you can get a feel for malpositions of these things. So first off, there is one lead that should be in the atrial appendage. It should be further down. It should have an anterior curve to attach to the anterior wall of right atrial appendage, but it isn't. It's in the SVC. Then we have this lead here. And what I didn't initially appreciate on the lateral projection is where that one is. So the leads are coming across the midline in the left brachiocephalic vein, but one of them just deviates to who knows where, and then goes right down there. And then the right ventricular lead and the coronary vein lead appear to be okay. Now let me show you the CT. So yeah, let me show you this. Let me bring up the coronal. So it turns out that the lead that goes in a very funny place leaves the left innominate vein, exits the left innominate vein about here. And then you can see one goes adjacent to the aorta but it's not in the SVC. So this guy, well, I can bring up this. Sorry about that. Is way anterior, and you can see it traverses the mediastinal fat to end up next to aorta or something. So it's not in the vein at all. And perhaps when they inserted that one, they recognized it was a problem, or at some point decided just to leave it there, not try to take it out. And then they put in the other atrial lead, which is malpositioned. And now we can also see, whoops, that the right ventricular lead is in the right ventricle, but the tip isn't. So the tip of the right ventricular lead has perforated through the apical right ventricle to terminate in the mediastinal fat. So, sorry, I'm not showing you the right place. There it goes right there. It goes up into the fat right there. So really a whole bunch of misadventures with these leads from the outside. So they weren't quite sure what to do with this lady, but they did end up taking the leads out. And now we can see they replaced and put in a new right atrial lead, which is properly positioned. They put in a new right ventricular lead. The other one that was extravascular is gone, and the other one is in the right place. So I don't know what to make of all that, but
There's a trifecta.
Yeah, that's a trifecta. I've shown you some weird stuff with, and I think multiple physicians in different places were involved with this lady.
Was there an SVC
Okay.
that led to perforation? Do you think there wasn't any stenosis in the superior vena cava that promoted something?
No, no. Because she came from the outside, we didn't have any information. No one had any information. She seemed to indicate that they had a problem putting one lead in, and that was probably that perforated lead, but we were not able to get any more information. She had been to different places, and there were no notes available that I could find. So here is a case that demonstrates the principle that, I don't know why this does that. Let me just unlink those and get the window back again. That, and here I apologize for the motion and sharpness. I don't have any images that don't have motion and sharpness, and I don't have any thin cuts, but I think you'll all agree that the abnormality, which is up here, little nodules, are relatively sparse. And of course, if you look at the chest radiograph from the previous month, that's very unrevealing. So this person has sputum into that. Oh, wow.
Was there lymphadenopathy, Howard?
Let's have a look to see if he has big nodes. Yeah, I'm not really sure. Well, let's see. That's SVC.
It's a little puffy above the aorta.
Let's see.
I think there's something right paratracheal.
Not there. I'm not sure this is all SVC or whether that's azygous arch. I don't know about here. I can't tell for sure. I'm not sure, David, for sure.
Okay.
He's got big nodes.
Kind of a,
But you know, this radiograph is pretty unremarkable, isn't it? He doesn't have big guys.
well, I thought it was a little convex above the aorta on both sides.
Okay.
On the
Somewhere,
radiograph. On the radiograph.
Oh, here.
Yeah.
Maybe.
on both sides. Yeah.
Not sure. Not sure. Can't tell.
Probably all the same diagnosis if it's real.
Yeah. I think the cyst is, I don't know what that little cystic space is, but tuberculosis.
Maybe left over from his pneumocystis.
Yeah.
Very thin walled.
Yeah, that's a bit of mucus in the airway. So once in a while, a person will have sputum positive TB with a relatively unremarkable radiograph and very sparse findings. Okay, this one I will show you. We've seen these before, but this is a nice example of this. So let me bring up this image to show you the left subaortic brachiocephalic vein. So here it goes. Instead of going across the midline to join the counterpart on the other side, it slips underneath the aorta, goes to the other side. There's a bit of reflux of contrast medium into it. But otherwise, a really super typical left or subaortic left brachiocephalic vein. Just a nice example of that. I think I see this once in a couple of years, more or less.
Yeah. Were there any other anomalies? Because it's sometimes associated with tetralogy of Fallot or other things. Pulmonary artery is big, but that's about it.
I think it always is side opposite to the breast prosthesis too. I think that's one of Kanne's laws.
Yeah, so it's obviously an oncology follow-up, breast cancer follow-up incidental.
And I think, I can't remember, one of you, or maybe it was Travis, showed a circumaortic left brachiocephalic vein. There it had two branches, one went around and one went under.
Yeah.
Cool.
Yeah. Just because we have a little time left, I don't have a diagnosis here, but I do want to show you this case. We discussed this last week in an interstitial lung disease imaging conference, and part of the reason I want to show you this is because people kept on pressing me about, well, terminology. So I described the findings, and I used the term emphysema, and they said, oh, this patient doesn't have cystic lung disease then? And then we got into a discussion about cystic lung disease and emphysema. And I don't know why that confusion arose in that context. But I think if you look at a case like this, and I hope you'll agree with me, let's first go to the areas of lung that are relatively uninvolved. I mean, there's a lot of disease here. And we see, for example, here that there are areas of, just let's call them transradiancy at the moment. And these have the distribution along pleural surfaces. We see these internal to the lungs, they're variable sized. And then we can see there is very extensive abnormality involving the left lower lobe in particular, and then to the right lower lobe as well. And to me, this is a situation in which I'm pretty confident that we've lost lung tissue. So this is emphysema in that sense. So the definition of emphysema is cases beyond the terminal bronchiole, and it's permanent with loss of lung tissue, but without fibrosis. And I think getting hung up on the cystic lung disease is a moot point, because this isn't the cystic lung disease we usually use descriptively to refer to things like lymphangiomyomatosis or other forms of cystic lung disease like Burtog-Dubé syndrome. Here in this lung here, which is very abnormal, there's still tissue there. The pulmonary vessels are very small, but they're coursing through this lung. So there is tissue there. And to me, this is very severe emphysema. Now, they do know that he doesn't have alpha-1 antitrypsin deficiency, but he's got, in my view, emphysema. I think that's definitely the case. I just don't know why he has this, or whether he's got some elastase issue that we just haven't diagnosed. But in terms of terminology, do you use the word emphysema to describe this?
I agree.
Yes.
I like emphysema. He's got pulmonary hypertension too. You know, one consideration around here would be Ritalin. Could this be Ritalin? Since it seems to be, it is basal predominant, isn't it, Howard?
It's definitely worse in the bases. It's pretty severe elsewhere. I don't know that he's a drug abuser, but that's certainly one thing to think of. Is written abuse producing severe emphysema, destruction of lung tissue. And I think the common denominator there is also ultimately elastase-mediated lung destruction.
Yeah, I mean, all the lucent spaces you show, Howard, I mean, for the most part, don't have perceptible walls. They have vessels within them, and the stuff on the periphery is typical paraseptal emphysema. Then you have more panlobular, where it's more confluent. And I agree with you about that. Because cystic lung disease doesn't usually affect vessel size. We've shown, we talked about that with some of the end-stage lamb cases where you see normal caliber vessels, and that's, you know, when it's mistaken for emphysema. And then in this case, yeah, you wonder about like an IV talcosis, like David suggested, or IV, you know, Ritalin or whatever, other things too.
Yeah.
Because it's looking more like a vascular distribution than an airway, given that it's so strikingly lower zone predominant.
Yeah. So I just don't know the diagnosis. I'm pretty confident what the pathology is. We just don't know what in this person the cause of this is. I know sometimes if you have really bad Langerhans cell histiocytosis in the upper lung zones, so-called end stage, that can be really hard to distinguish between a lung that looks like this. But
Howard, did you say this is a young guy?
yeah, this is a youngish person. 40.
40?
Yep.
I would really I really go after what he inhales or injects.
And maybe it's a false negative alpha-1 antitrypsin. They can evaluate that again just in case it's a false negative.
Right, some unrelated but untested, you know, variant of that pathway. Right.
Yeah. Yeah.
All right.
So there you go.
Thank you.
If I ever find out, I'll let you know.
All right. Okay, well, that's it. And it's just about 3 o'clock here. So I'll talk to you guys next week. Thanks for the great cases.
Okay.
Thank you.
All righty.
Bye.